All right, good morning. Welcome to In the Trenches with DAC. Today, one of my residents gave me the topic leukemia to talk about. This is a very broad topic, and I'm going to attempt to accomplish this task in 10 minutes. That's a task that really cannot be done, but I'm just going to go over a basic overview. So when you talk about leukemia, the basic points, you have acute and chronic, myelogenic, and lymphocytic. This is the basic point. You can basically break these into 4 disease subgroups. A lot of them have other characteristics about them. So with the acute leukemias, you have AML and ALL. Okay, AML, you have different subtypes. They're really, in the old classification, you had M1 to M7. Now they do more of this with chromosomal abnormalities. I'm just going to put these on the board. But this has evolved. M1 was myeloblastic, M2 was myelocytic, M3 was acute promyelocytic. This is important. M4 myelomonocytic, M5 monocytic, M6 erythroblastic leukemia, and M7 megakaryocytic leukemia. The M3 variant, acute promyelocytic leukemia, is really a distinct entity because it's treated differently, and it's very granulocytic. It could be associated with DIC, and it could be treated actually with arsenic. But in addition to chemotherapy, it's treated with retinoic acid and sometimes arsenic. It makes the cells mature. This actually has a better prognosis. The monocytic leukemias could infiltrate organs like the skin and the lung, and they have a stronger association with that. But if you're concerned about acute myelogenous leukemia, and to go over prognostic factors, there's flow cytometry and chromosomal cytogenetic abnormalities you're going to look for, and that's beyond my pay grade. This is more common in adults. Now, acute lymphocytic leukemia is more common in kids, but you can see this in adults, and this is often presents. You can have mediastinal masses, mediastinal adenopathy. This is treated with chemo. The prognosis in kids is good. In adults, it's probably worse than AML. There's a different chemo, and these people also get CNS irradiation. They have their spinal cord irradiated. There's a higher incidence of infiltrating the CNS. To treat AML, they're going to get chemotherapy. And after they get chemotherapy, stem cell transplants, what done, and 40 to 50% of these people have long-term survivals, and that's really the ultimate goal in both these leukemias, to get them into remission with chemo, and possibly to do a stem cell transplant, provided you're able to do that and the patient's well enough for that. ALL more common in younger individuals. Now, the two chronic leukemias, CML and CLL, have nothing to do with each other. CML is a myeloproliferative neoplasm where you have a lot of white cells. And the way it used to work, these people would eventually develop AML. There would you would progress, and once they developed that, they did not respond. They did not respond to the chemo well. Now, and this is really 15 years old, these disorders are treated with tyrosine kinase inhibitors. The first one was amitinib with Gleevec, and they have newer generations, and these really put these patients in remission. They put them in hematologic and cytogenetic remission. What this was associated with was the Philadelphia chromosome translocation 922, which is called the BCR-ABL antigen. Abelson, bright chain region, Abelson oncogene. And these people, that's how you diagnose this. These people often have very big spleens, but it's a different type of disease. You have extensive long-term survival. It used to be a disease where people over 3 to 5 years, they would die. Chronic lymphocytic leukemia is a disease more common in the elderly, but you can see it in young people also, and these people have a lot of lymphocytes, and basically they have over 5,000 lymphocytes. You do flow cytometry, and they have on the blood, and they have increased CD5, 19, and 20. And this is a disease initially, I mean, the thinking with this is people die with it and not from it, and it's still often the case. They have better treatment. It used to be treated with alkylating agents and prednisone. Now they have medicines like ibrutinib, and you also have BCL2 inhibitors, venetoclax, and if it's really severe, sometimes they use CAR T cells for this also. So this is a medicine, this is a disease entity rather, that there are a lot of treatments, a lot of advances, more common in the elderly, and really to prognosticate it, you need to get chromosomal studies. They will tell you if somebody's high risk or not. A lot of people with the low risk phenotype of this, they are just going to be followed clinically. So this is leukemia. This is a very basic, broad overview. There are other variants of leukemias, but these are the 4 major leukemias. They have a lot of subtypes within them, subtypes of AML. There's subtypes within ALL also, especially the acute leukemias. And with this, I'm going to stop. Thank you.